Well, thank you very much, Faisal. That's a great talk and a great update about the endovascular treatment. Um, we'll move gears a little bit. Endovascular therapy, not always an option, and some patients and some lesions are challenging and still need surgical approach for revascularization, which what I will be talking about. Can you guys see the slides?
Yes, we can.
Okay, so we'll move on. So as you heard so far through the other talks as well, the revascularization strategies for CLTI that we have to restore inline flow to the foot, especially in the case of tissue loss. We need pulsatile flow inline all the way to the lesion because treating the proximal lesions in the setting of a distal occlusion will not be adequate for wound healing. And after that, we have to have surveillance and vigilant follow-ups, which we already talked about through clinical examination and duplex. And we should always have a low threshold for re-intervention, including conversion to open surgery or endo failure. And as you saw, the endo option is a great option. However, the CLTI patients are very challenging. And one of the challenges that the endovascular treatment faces, the disease in the CLTI patient is usually multi-level and long. They have long segment with chronic total occlusions that sometimes difficult to treat. Also, these patients have extensive calcification due to diabetes and renal disease. On the other hand, they have advanced tissue loss, which will have a very large perfusion requirements because these large defects may take weeks or months to heal. So patency is important. Also, we may have flaps like the transmetatarsal amputations where we'll need a lot of blood flow to be able to heal. Also, durability of treatment is very important as the diabetic foot ulcers have recurrence rate with 20 to 80%, and 70 patients will survive more than 2 years. So, so for strategy and the key factors in the decision making, we have to look at the general health of the patient, age, comorbidity, ambulatory status, the foot and the likelihood of functional salvage, severity of limb ischemia, anatomic distribution of disease, if the patient had prior vascular interventions, and the availability of autogenous vein for lower extremity bypass, including great saphenous vein and alternative veins, which are in the arms and the small saphenous vein. And always prosthetic has inferiority if vein is not available. So infrainguinal bypass is the gold standard. Results well documented. It's versatile with low mortality and good durability, but it has its limitation and risk. Has wound and other complication, prolonged recovery. Vein quality is very important and sometimes is not available. As you know, many of those patients' veins already used for coronary artery bypass. Surveillance and reintervention, lifelong and technically demanding. And this was well documented in the PREVENT-3 study, where they studied 1,400 patients, and they showed that lower extremity bypass can be done with very low risk, including stroke, cardiac and respiratory arrest, less than 2%, and the amputation rate was very low at 1.8%. The patency was very promising. It was 61% primary patency at 1 year and secondary patency of 82% at 3 years. And these patients were sick patients. They 75% of those, they had tissue loss, where 25% have high risk conduits and 66% had tibial targets. So they were not cherry picked. So how do we do our bypass? We start, as you heard from the Dr. Sereno and Dr. Rivard, we start with preoperative imaging. Then once we diagnose it with non-invasive, we obtain high quality imaging for planning. If the patient has concomitant iliofemoral disease, we go ahead and treat it, and the treatment of choice still endovascular. Like the patient on your right hand side, he had left common iliac artery stenosis that was treated with a stent. Then we define bypass target arteries by angiogram, and we should have a DSA with dedicated multiple views of the ankle and foot. AT and PT preferred over the peroneal because they go directly into the foot and they have anatomical advantage for exploration as well. Then we assess with ultrasound and vein mapping, autogenous vein, if starting with the lower extremities with the great saphenous vein, and then if not available, we look at the small saphenous vein and bilateral upper extremity veins. What we're looking for soft, compressible, and at least 3 millimeter diameter veins. So this is the conduits. We talked about the vein conduit. If we don't have vein, we use prosthetic. Heparin-bound PTFE and Dacrons are the most commonly used. And if biological ones are preserved for the infected fields because they're expensive and they have low patency. Bypass technique, we start by proximal exposure, which is the most common site is the common femoral artery. Sometimes the disease includes the common femoral artery and the patient requires common femoral endarterectomy. Like you see in this case, the patient has disease in the common femoral artery causing significant stenosis and complete occlusion of the bifurcation of the superficial femoral artery and the profunda. We endarterectomize it and patched it with double patch. Then we can carry on with our bypass. Then we explore the, of course, these are not done in this exact order, so we do both explorations. We do the distal exposure, the one that was identified on angiogram. We harvest the conduit, which we already know that it's good quality based on our preoperative planning. Then we tunnel, and the tunneling can be anatomical or subcutaneous. And then we configure the conduit, especially with the vein, whether it can be used reversed or in situ, which will need venolysis. Here you see the distal anastomosis. We perform it in running fashion, and this is actually a dorsalis pedis anastomosis performed by saphenous vein bypass. When we finish with intraoperative completion studies. Those can be done with Doppler. We listen to signals with and without compressing the vein bypass or the bypass. And the most modality to test that is completion angiogram, which you see on your left, on your right-hand side. This is the vein where it feeds a very small posterior tibial artery, which usually dilates afterward after it's revascularized. And the best time to pick up a technical error is the first operation. What we're looking for dissection, clamp injury, conduit kinking or bleeding, or missed valves or thrombosis of the bypass or the target artery. Post-operative management, we have to keep close monitoring for the patient cardiovascular status, including angina, arrhythmia, CHF exacerbation, hypertension. Everyone gets antiplatelet therapy, and we usually consider anticoagulation in high-risk bypass, which is usually defined as poor arterial runoff, suboptimal vein conduit, prosthetic conduit below the knee, and reoperative cases. Wound care, we have to keep close eye on all incisions, and remember these incisions are in ischemic leg. And then for the ulcer that we started the whole case for, if the infection is controlled, we allow for tissue demarcation of devitalized tissue before debridement, and then we plan for that within 4 to 2 weeks, depends on the severity. 4 days to 2 weeks, sorry. Post-operative management surveillance is very important to keep that pulsatile flow going until we heal the ulcer and hopefully to prevent recurrence as well. We perform physical examination, arterial duplex every 3 months for 1 year, then 6 months for additional 2 years, and annually after lifelong. We're looking for intimal hyperplasia, especially at the proximal and distal anastomosis, progression of the proximal distal disease or lesions within the graft itself. And the threading graft with the findings of pre and post stenosis of 3.5 or drop in ABI of more than 0.15 should undergo angiogram and correction of lesion to maintain the patency of the graft. Because as mentioned earlier, sustained hemodynamic improvement is the most direct measurement of effective revascularization therapy, not just the first result. So, in conclusion, bypass, they're technically demanding, but they're very satisfying as well. And I'll leave you with this quote by Vince Lombardi: "The harder you work, the harder it is to surrender." And thank you very much for your attention.
Thank you, Hassan.
So,
That was a wonderful talk. Really appreciate your input. And if you want to go ahead and introduce our next speaker.
yes, so we'll continue with our limb salvage team, the indispensable part, Dr. Gulnar. Dr. Gulnar is a very well experienced and passionate podiatrist. She will tell us the role of podiatry in limb salvage.